All right, so we are right at 12 o'clock, and I'm going to go ahead and get us started. I want to welcome everybody to Medical Grand Rounds at the University of Colorado. Just as a reminder, we're back now in Bruce Schroffel Auditorium on the first floor of AIP2. Really encouraging everybody, not only for the learning, but for our sense of community, to come back in person to all of our grand rounds. A little bit of a teaser for those who are thinking about coming the next few weeks. On October 11th, we're going to hear from Dr. Tracy Bale. She is the Anschutz Foundation Endowed Chair in Women's Integrated Mental and Physical Health Research at the Ludeman Center, and she's going to talk about stress dysregulation in children and its effect on adults. And then the week following, on October 18th, we're going to hear from our own Dr. Jane Roosh, who's going to speak about exercise, diabetes, and longevity and her translational research journey. A lot of you probably know Dr. Roosh. She has been publishing many of the articles in the New England Journal for the past 3 to 4 months. As a reminder, there's CME and MOC credit for all grand rounds this year. Questions will come from the live audience. Also, thank you to the chief medical residents who will be watching the Zoom Q&A for folks who are watching at home. Now, I am really very pleased to welcome today's speaker, Dr. Taison Bell. Dr. Bell is an associate professor of medicine at the University of Virginia in the Division of Pulmonary and Critical Care Medicine, as well as an associate in the Division of Infectious Diseases. He is the vice chair for faculty affairs in the Department of Medicine, a principal investigator for the UVA Summer Medical Leadership Program, and the founder and CMO of Owl Peak Labs, which we may or may not hear anything about this afternoon. He did his undergrad work at the University of Virginia, where he majored in African and African American studies. He was a medical student at Columbia University. He was an intern and resident at the Massachusetts General Hospital, where he also served as a chief medical resident. He did his fellowship in infectious diseases at MGH, and then went to the NIH at the Bethesda program for his critical care medicine fellowship. In addition to that, he received further advanced training when he received his MBA in 2020 from the University of Virginia's Darden School of Business. Dr. Bell is somewhat early in his career. It's fun to be able to still say that for folks, but he's already had a remarkable journey. He has served as the medical director in his ICU. He is a physician co-lead of the Mortality Coalition, a quality officer in the UVA Quality and Safety Program, among many other local leadership roles. He's received numerous awards for his leadership, his teaching, and his skills as a physician, which include the Junior Faculty Teaching Award, the Top 40 Under 40 Leaders in Minority Health, and the Top 30 Under 40 Leaders in Transforming the Future of Healthcare from Business Insider. Most recently, he was awarded the Department of Medicine Excellence in Teaching Award, as well as their Distinguished Scholar Awards in 2022. His clinical research is centered in the ICU, where many of you know his name from his COVID-19 work. He's also co-investigator for the PEDAL Network and combines his knowledge of ICU care and infectious diseases with an additional focus on the application of artificial intelligence and machine learning and deep learning algorithms into the clinical environment. And I think I'm most impressed with Dr. Bell and really happy to welcome him here today, because he's a master communicator. And he's a leader in health education, leader in healthcare delivery, someone who takes care of his patients incredibly well, but also the healthcare community at large. So it really is a pleasure to welcome today Dr. Taison Bell.
Thank you. Thank you for the kind intro. It made me tired. I'm doing too much stuff. But I should show you my email inbox, and then you will see the other side. Because I'm not good at responding sometimes. So let's get right into it. I'm glad I have a nice stage I can walk back and forth along. Title of my talk is So What You Sayin'. This was an EPMD song from the 1980s off their first album. And it's really aimed, so I do talks for selfish reasons. I want to make myself better. I want to learn about something. I encourage you guys to do this too. So the first version of this talk was just in the height of the pandemic. I was talking to ID professionals, public health communicators, just about how to talk to the media, how to do social media. Not that I'm an expert, but I was doing a little bit of it. I was coming out of my Darden program right into the pandemic, and I had literally just taken a mass media communication course and a leadership development course. So I was like ready to go with the ID and critical care training background. But now that the public health emergency part of the pandemic is over, I'm back to doing the things I want to do, which is just being a doctor. We're in the room because we like being doctors. And so, like many of us, when we go through something that is challenging, maybe traumatic at sometimes, you want to make it worth something. And so this talk is an effort to try to bring back the lessons I've learned from communicating on a mass scale back to the patient bedside. So first thing I have to do is acknowledge the people who have allowed me to be here. And this is quite literally because my family, we discuss the trips that I take and they give me the yay or nay, and they allowed me to come here. So Kristen is my wife right there. Very beautiful, very intelligent. She's also the reason why I cannot work from home. She is an opera singer, and her voice overpowers any noise cancellation headphones. So I have been in the office. Elaine, my son, who's 9 years old, very kind, gentle soul, wants to do the right thing, wants his parents to be proud of him. Really, really sweet kid. And then my daughter Ruby, who is she's not that, but we'll get to her. So here's my outline. I'm going to talk about three main things. So first, I want to outline some of the principles of mass communication in public health with an emphasis on social media, but it can expand other areas. I want to discuss combating misinformation and disinformation, because that was one thing that we just saw constantly early on in the pandemic and even still now. And then finally, connect the above lessons with communication back to the bedside. So hopefully you can take some lessons from this talk and apply it immediately when you're seeing patients. All right, so first section, how to communicate with a lot of people. This was a lesson I took away from business school, and I laughed at it when I heard this concept of what's your brand? What's building your brand? What's your why? Your brand is basically the reputation that you want to establish, the range of topics that you want to cover, because you can't be an expert on everything, and then your general communication style, your general philosophy, and your worldview. So basically, if someone hears your name or sees that you're talking somewhere or that you're posting something, they kind of know generally what they're going to get, so that you're not so much of a wild card. Now, I had three major categories that I came up with when I was thinking about, well, what kind of brand did I want to build within the communication I was doing? So first is the advocate, the person who advocates for a community that needs someone to advocate for them. These are people who, like Ebony Hilton, who is an anesthesiologist at University of Virginia, who does a lot of work with racial disparities and DEI. Dr. Kimberly Manning, who's at Emory University, who's a hospitalist there, who's a fantastic person, individual. The Blackstock sisters, Uchi and Oni Blackstock, who are both in New York City. These are people, when you see their work and their name comes up, you know the angle that they're coming from. They're going to advocate for their communities. The next category I would put as a subject matter expert, people like Carlos Del Rio, president of the IDSA, Dr. Peter Hotez in Texas, Caitlin Jetelina, who's a public health professional epidemiologist, who has a really good Substack. These are people who know the material inside and out. If you have a question, they're the ones that you go to if you need some knowledge imparted to you. And then there's a policy wonk, because of course, with something like COVID-19, you have to take the advocacy, you have to take the subject matter, but you have to translate that into policy decisions that make an impact on people's lives. So my good friend, Cameron Webb, who just finished a stint on the White House COVID response team, he's also at the University of Virginia, really engrossed in the policy part of things. Ashish Jha, who led the COVID response, Vivek Murthy, the Surgeon General. These are people who are really in the policy weeds and know how to implement and get something done on the policy side. Now, of course, I'm presenting these as if they're silos, but there's crosstalk between the two. So of course, you can be an advocate and a subject matter expert, know the policy, et cetera. And I tried to position myself as someone who was, admittedly, I'm overtrained with ID and critical care, kind of met this moment. So being a subject matter expert made a lot of sense, but also I wanted to be an advocate for the community. I'm an African-American. I was in Charlottesville, close to the community where I grew up in. And I had a close connection with the policy people as well. So I tried to put myself in the middle category, but with some crosstalk there between the two. So now, here's a lesson I had to learn early on and reconcile with, and this is general life advice. You don't have to be the expert on something in order to be useful for communication or really for anything else. And as an ID and critical care doctor who works at an academic center, I've had to get used to this pretty much right away. So for instance, if I'm going to be grounding in the ICU tomorrow here, and if I see an echo images, I'm going to look at the echo images and I'm going to have some thoughts and opinions about what's going on. But if this guy rolls up beside me, Dr. Allen, he's going to know those images better than I do. He is literally better at this than I am. That doesn't mean I'm not useful, but there's someone who can do it better than I can. I do infectious diseases. I do a few weeks of consults a year. So if I'm talking about antibiotics, if I'm in a clinic, and this guy rolls up, he's going to know more about this than I. He's going to have a lot to say probably. But he's engrossed in it more than I am. And so I'm not the expert when it comes to even to a field that I'm boarded in. I work in the ICU primarily, and I do bronchoscopy, but I did not do pulmonary, which means I did not do outpatient bronchoscopies. And that means that my numbers are relatively low compared to a Pulm fellow. So this guy, who is our I think is a second-year Pulm fellow, who came from UVA, Izzy Butnick, great guy. He will soon enter the point where he will have done more bronchoscopies in his career than I've done in my career. And he's going to be better at me than this. That doesn't mean I'm not useful, but it means that there are someone who can do it better than me. And of course, I talk about clinical trials and studies and things to do with the NIH, but I'm not this guy. All right. Now it turns out he was pretty busy during the pandemic, and he needed other people to talk about COVID. So I could still have a role, even though there's going to be someone in my place of work who can do something better than I can. And I want you guys to remember that just because you're not the expert, you might work in a place where there's an EP person who specializes in the left bundle. That doesn't mean that you can't be useful, okay? All right. Now, one thing you do want to do is establish what your credibility is, all right? So Josh right here, I'm taking a screen grab from his profile page. You want the audience to be able to easily identify your expertise. You want to show your connection to your institution if you want to. And then if you need to, separate yourself from your institution, opinions are mine, that sort of thing, and include a little bit of your personality. So let's analyze right here. Infectious disease, Director of Social Determinants of Health and Disparities Modeling Unit. So at CU, so we know exactly what he does. He shows his connection with his institution. He does not separate himself from the institution, but Josh doesn't care about that. And then a little bit of his personality. You see the picture right here, keep your coins, I want change. So that implication there that like he's an advocate, but he's the advocate in the sense that he is radically moving towards change. And he's not just doing it for the credibility. So you automatically get a sense of who he is and what angle he's coming from. So good job, Josh. All right. The PACE principles of communication. This is going to be the majority of the talk, but there's 5 principles that we'll talk about. The Arthur Page Society is a society that authored these principles. There's more than this, but these are the most important ones in my opinion. They're like the AMA of public relations professionals. So they kind of write the rules for PR firms when they're working with their clients. And so 5 of these principles: tell the truth, prove it with action, listen to your stakeholders, manage for tomorrow, remain calm, patient, and good humor. So this is what we're going to talk about for the next portion. So first part, tell the truth, which sounds very easy. Just don't lie, right? But telling the truth can be hard when it comes to talking about science. I felt like in the beginning of the pandemic, I was telling the truth to a bunch of people who didn't want to hear the message. We have to mask, we have to be inside, we have to quarantine, socially distance. And then towards the end of the pandemic, I was giving good news about vaccines and being able to go back to normal life and our treatments, but an audience that wasn't receptive to it because they were anti-vax. And so in both sense, I was giving bad news at first and what I felt was good news towards the end, but with the audience that I was struggling to connect with. And that's because this concept is actually pretty hard. So what makes it hard? So this is what I think made it so hard, is that communicating truth with uncertainty is extremely difficult. And just the way science is structured versus news makes this an opposition. So science, for instance, moves very slowly. It's filled with uncertainty. When we talk about science, like in Journal Club or in rounds, we use a lot of language just for the purpose of describing that uncertainty, your p-values, your confidence intervals, your odds ratio. And we talk about the limitations in studies. If we don't have limitations, we kind of question the validity of a study. And so it's an iterative process. It changes over time. And so, you've probably heard in med school, by the time you're practicing, half of what you learn in med school is wrong. And that's because it's an iterative process. Now, contrast that with the news media, where the currency is certainty, is black or white, truth or fact or fiction. It moves quickly. Certainty is really the name of the game and is very declarative. And so it's in fundamental opposition to how science works. And so once the science has been worked out over decades and decades, and we have some more certainty, like statins reduce the incidence of cardiac disease, it's declarative at that point. But early on, when we're trying to figure out what a virus is and how it operates and what treatments might work for it, there's going to be moments where we have to iterate on the knowledge that we knew before, but it's in the news media, then that becomes a problem. So that was the first challenge that a lot of us had when it came to communicating around the pandemic. And there was actually a study that looked at this. This was in 2021, so relatively like midway through the height of the pandemic. 1,500 adults that were read one of 5 different versions of the same information about COVID-19. And they assessed for what they called ambiguity aversion, which was a combination of your likelihood from getting COVID-19 or your perceived likelihood, your overall worry, and your intent to do things like social distancing, masking, et cetera. The study period was May to June of 2020, so right when things were starting to pick up. These were the 5 categories: the control, which was the baseline statement; the control, where they added some uncertainty into the statement. I'll show you examples of this. And then normalizing that uncertainty, saying that this is something that's not unexpected. Hope promoting is the optimist part, like we'll get to the promised land at some point. Then the pro-social, we're in it together, look out for each other. So here's an example. The control, COVID-19 is a respiratory illness caused by a type of virus that infects human beings. Very contagious, spreads person to person, respiratory secretions, all things that we know. Anyone can get COVID-19 and nobody is risk-free. Very factual statement. That's the control. Now we're going to introduce some uncertainty into the original paragraph. That's what the underlying portion right here. So you start by saying there are many things we know about COVID-19 and many things that we don't know. So introducing that. And then at the end, it's impossible to say exactly where it'll spread and who will become infected or not. So again, introducing this notion of the uncertainty part of it. Now, if you normalize that uncertainty, this is adding the bold text to the underlying text in that original paragraph. So right now, there are many things we don't know. The implication that we'll know at some point, and at the very end, impossible to say exactly where it will spread and who will become infected, but this is true of all diseases. There are always risks, and the goal of medicine is to reduce these risks. So this is introducing a notion of, yes, this is a different day, but it's the same sun. We're dealing with the same kind of problem, and we'll eventually get there, and we're going to normalize this concept. All right, so let's take a look at what they found. So this was panel B was the worry over COVID-19. You can see the control, the baseline score was around 3 on a scale of 5, a little above 3. And then once you introduce some uncertainty in the other statements, then it goes up a little bit. All right, but what was really interesting was how it broke by political affiliation. So let's start with the control. So your control statement right here, you can see the baseline worry, they're more or less the same around on a scale up that goes up to 5, around 3.5 or so, between 3.25, 3.5. Now, if you introduce the uncertainty part, this was the many things we know, the many things we don't know. You see that worry goes up most for Democrat, but it goes up for everyone. But now look what happens once you normalize that uncertainty, once you introduce the concept that this isn't unusual that we don't know, but we don't know. You see worry actually goes down if you're Republican, and it goes down a little bit if you're Democrat, but certainly not to that extent, somewhere in the middle if you don't have an affiliation. And now, if you're hope promoting, the optimist part, Democrats seem to take that the opposite direction. And then if you introduce pro-social messages that we're in this together, we need to look out for each other, those sorts of things, that's when it goes through the roof. If you're a Democrat, it plummets if you are Republican. So there are 2 gaps here. There's a worry gap that I put here when you introduce uncertainty, because there was certainly a different amount of worry between your political affiliation. And then here, let's call this the empathy gap, where if we're talking about looking out for others, that's when the concern goes way up if you identify as a Democrat, and way down if you identify as Republican. So the problem with communicating in COVID-19 is that you don't select your audience, or hopefully you're not, because you have to communicate information to a virus that doesn't really care what your political affiliation is. You've got to get that message across to both audiences, and they respond in different ways to literally the same message. So that was one challenge. All right. The other challenge, numeracy in the US. It's an issue. All right. And this was a survey that looked at level 2 numeracy among different countries here. Level 2 numeracy means you can add and subtract 2-digit numbers. So 14 minus 10, that sort of level. Now, one issue here is that, all right, look at the US. 29% of adults 18 to 29 years old have low numeracy in the US, okay? That should be the peak. It's not going to get any better from that point because most people have finished school. And look at that compared to other countries. We're certainly doing pretty bad when you look at most of Europe, certainly parts of Asia. We are a relatively low numerate society. Literacy is your comfort with words, numeracy is your comfort with numbers. We're a low numerate society. Now, this room does not have an issue with numeracy. You could not have made it to this room if you weren't good with numbers. But the issue is we communicate amongst each other all the time at a high numerate level. When we have to communicate with the public, there is a lot of difficulty with interpreting complex data. And if you listen to COVID-19 reports in the news cycle, they're talking about studies, they're talking about statistics, they're talking about things that people generally struggle with in our country. So how do you communicate data in a way that people can actually relate to? This was a second big challenge. And so one way was just to try to keep it simple. And you've all heard this, we need to communicate at a level that our patients can understand, but it actually is pretty difficult. CDC actually does a pretty good job of this, and that's because they have a whole team who looks at their messages before it goes out. So this is an example, a reminder to get your COVID-19 vaccine update. They're not calling it a booster because their focus group said that booster is not received as well as COVID-19 vaccine. So they changed the language there. But everyone 6 months and older should get an updated COVID-19 vaccine. It's short and sweet. There's no jargon there, no more than 3 or 4 main points. And then they've been repeating this message because repetition is good. So this is the ideal. That doesn't mean it's going to be received the same way, but at the very least, people can interpret the message in a way that makes sense. Using visuals is something that really helps. Tweets with images receive 18% more clicks, 150% more retweets, and we remember visual information around 6 times better than reading or hearing in isolation. One thing that the country has noticed about Colorado is that it's an interesting, exciting football season going on. So, of course, the medical campus has to be the mom and dad in a room and remind these undergrads that you should have hearing protection on when you're in a stadium. So we've all been through college. How do you think that information is going to be received? But it was more likely viewed more because there was an image associated with it of undergrads having fun. All right, so use visuals. Now, one thing that I learned through the course of the pandemic was how to communicate, but it was for me an iterative process. And this is what I'll call my SciComm internship, so to speak. So early on in the pandemic, I teamed up with my good friend Cameron Webb. We went to college together and came back to UVA at the same time. Our families are friends with each other. We started this weekly 1 hour long Facebook live stream that had a loose structure. It was just a 2 to 3 minute update that I gave on the pandemic. And then the rest was community questions and anyone could log on. Of course, we got trolled at times, but it became a community where people just asked questions and we struggled with it. And we said, I don't know a lot of the time. And we ended up doing, we went for a little over a year and did over 50 sessions. Lots of dad jokes. We're both kind of relatively corny people. We were cool back when we were in college, but we're definitely not anymore. So we did the Christmas episode that you see right here with the Christmas sweaters, and it was a whole thing. But this was where the community could log on every Monday. It was between 7 and 8 o'clock. I got to get out of bedtime for the kids, so there was like a benefit for me. And it was where I learned a lot of these lessons kind of organically because I didn't have like a slide set to look at and things like that. Now, one of the things that we encountered early on was misinformation just spread like wildfire, and that there was like a tweet that came out or someone was promoting some anti-vaccine stuff. we could pretty much count on it being a topic of discussion at our Facebook Live whenever the next one was going to come. This was a study that actually looked at the propagation speed of false information versus partially false information. This was taken during February 2020 to July. So this was the first major wave of the pandemic. And this equation right here, I don't mean to bring out PTSD from your calculus class, but in your numerator here is just number of retweets, and then C is the number of comments. And then at the bottom, N sub D is just the number of days that a tweet was kind of circulating. And so basically this is a measure of how viral something goes, because if it propagates really quickly in a short amount of time, then that's a viral tweet. So as you can see here, false information during March, this was when New York was really feeling it, really spread a lot more rapid than partially true information or partially or false information. And now what would have been interesting is to see how this changed over time as like the Omicron and the Delta wave and vaccines came out, but I hadn't seen any follow-up studies. But this just shows that idiom that a falsehood can make it around the world, twice as fast, that actually is true, because these narratives can spread a lot quicker than you think. Now, that made me ask the question, well, who actually is susceptible to mis and disinformation? There's some interesting findings here. This was another study that looked at your likelihood based on certain demographic features or geography to be susceptible to mis and disinformation. So on this graph here, if you're left of 0, you're less susceptible to disinformation. If you're on the right, then you're more susceptible. And this is different countries. So Ireland, Mexico, Spain, the US, and the UK. A very different range of topics or countries. And what was interesting here, if you were underrepresented minority, in any of these countries, you are more susceptible to mis and disinformation. So there's a common linkage there. Maybe it's a marginalized population, maybe different access to resources, different access to information, or distrust in the government. But among these different countries, you tended to be more susceptible to disinformation if you were URM. Not surprisingly, if you had high numeracy and if you had inherent trust in science, then you were less susceptible to disinformation. And also not surprising, if you got the majority of your news from social media, you were more susceptible to disinformation. Now, one thing that stood out was the WHO right here, generally kind of middle of the road, but there's one, Mexico, tended to have less susceptible to mis and disinformation. And that's actually because the Pan American Health Organization, or PAHO, is the best functioning WHO office. And they've been doing really good work in the South Americas for a long time, or Central and South America for a long time. And so they have a lot of trust in those communities. So they're kind of an outlier there, which I thought was pretty interesting. But as you can see, there are some linkages and some common themes for disinformation, even though everyone is susceptible at some point. All right, so how do you combat that? Well, this is the truth sandwich method, which was pioneered by Dr. Lakoff, who's he's a linguist, actually. And you take advantage of the fact that we tend to remember best the first thing that we hear and the last thing that we hear. So if you want to talk about or discount something that's false, you start with the truth, you introduce the falsehood that you're trying to dispel, and then you end with the truth again. So you're like giving it a truth sandwich. Here's a tweet from Jay or an X, whatever, from Jay Rosen. You state what's true, report the falsehood, and then follow with truth. So at the bottom, there's no clear evidence of hydroxychloroquine. Remember that, we were talking about that. An anti-malarial drug protects against coronavirus. Donald Trump says he's taken it, but his doctor would not confirm it. That's introducing the person who's using it in a false way. And then medical experts have said that it could have dangerous side effects. So that's layering in that false information or what could be implied to be something that people should do, but is actually false, but layering in with truth. And so I learned to do this when I was answering a mis or disinformation question. Start with something that was truthful, talk about the falsehood, finish with the truth. Okay, next principle. Prove it with action. Can't believe what you say because I see what you do. And this goes into the general thing that patients have. There's fascination with how doctors live their lives from like a health standpoint. Patients generally, in the public, are generally interested in the health decisions that their healthcare providers make. And we also tend to be better listeners when we humanize the person that's speaking to us. And so they're not just a part of the medical establishment, but they're the person who's just talking to you. And we're more likely to recall narratives, and we'll get back to that. And so one thing, so when the vaccine was available to children, there was like this big debate. I mean, children was just a polarizing topic across the scope of the pandemic: schools, masking, vaccines, et cetera. But one thing that I talked with my family about this, but we allowed our kids to get involved with some of the messaging. And so this was an article where Katie Wu, who was she was a writer for the Atlantic at that point, or with the New York Times. She's at the Atlantic now. She interviewed my son, who was 7 years old at the time, and asked him, what does he want to do after he gets vaccinated? And he told her Disney World in Australia. And that's a reminder that I have not done those things yet. And he wants to play basketball. He has done that, and go to any restaurants that have French fries, which he's done plenty of that. But this was interesting because a lot of parents actually shared this with their similarly aged children. And in a way, it encouraged a lot of them who may have had some, just didn't want to get a shot. They were vaccine hesitant just because they didn't want the pain. But this was a way to say, well, Elaine is going to go to Australia after this, and wouldn't you like to travel and things like that and be safe? And so it was a nice way to both humanize the message I was giving, because I was saying, this is literally what I'm going to do with my children. And so I wasn't this like COVID doctor or this this liberal who's like spewing all this mis and disinformation, but this is what I'm doing with my family. And that tended to help. All right, next one. Listening to your stakeholders. Jane Goodall was an animal rights activist. She loved chimpanzees. That's who she studied. And she had a series of sit-downs at one point with illegal poachers who were poaching chimps. And she said that change happens by listening and then starting a dialogue with people who are doing something that you don't believe is right. This was my friend Cameron Webb at a barber shop in Charlottesville, Virginia, talking to someone about the COVID-19 vaccine. There's a lot going on in this picture. So one thing is that Cam has gone to the place where they congregate. So there's a power dynamic that's dissolved right away when you go to someone's visiting field, right? Remember we talk about home field advantage? We often forget that when we're in the clinic and in the hospital, we're the ones with home field advantage. We know the place. We know where the good and bad food is. We know where the Wi-Fi reception is. This is our home in a sense, but it's very different for a patient who's coming into that environment. But he goes out to where they are so that he automatically feel more empowered. Also notice that he's sitting down. When he spoke with them, he always sat down to get at eye level with them, because that power dynamic of standing and a patient who's in the bed or a patient who's sitting down, that is a visual reminder of the power imbalance there. When you're actually talking about someone's health, you want them to be an equal participant, or at least feel empowered to ask questions that they have. So he's sitting down and making eye contact at their level. And then he spends more time actually listening than talking. And so with those three elements combined, this is where he started to get information that I heard the vaccine caused you to become infertile. I heard that the vaccine causes you to change your DNA, and I've heard this and I've heard that. And a lot of things that would not necessarily be shared if we were doing things traditionally the way that we normally do. And so listening is, it's both something that we're trained to do, we're supposed to do, but we have to remember that sometimes the way that we set up the listening environment can negatively contribute to the information that we're getting, to the detriment of patients. All right, manage for tomorrow. We're moving all along. Who remembers what this picture is in the background? All right, this was Brandi Chastain, FIFA World Cup final. The photographer, Robert Beck, he was a good sports photographer. He knew that Brandi tended to run to one side of the field or the other when she scored a goal. And he just chose a side during a crucial game. He had a 50-50 chance. She came to his side, and that's the shot that literally changed the future of U.S. soccer. It was a key moment because girls saw that and said, I want to play soccer. And it changed the face of the sport in this country. The most important thing is anticipation, not where the action's taken in place, but where it's going to take place, not where the subject is now, but where they're going to be. So how does that apply? This made me think of the adoption life cycle, the Rogers bell curve. So How many of you, when the new iPhone comes out, well, now it's like 13 generation or whatever, but early on when they were new and they were more novel, how many of you would get in line at the Apple store and be the first ones to get the phones? Come on, guys. All right. So you guys were the innovators and early adopters. All right. So notice there weren't many hands in the room. That's because there aren't many people who jump in line to do the first thing. So very funny. The chief took me out to lunch. And he took me to what was the name of it? What was it? Say it again. Okay. And it's like choice overload. And everything looks good, but I don't know what to get. It's my first time here, my first time in Denver. Like, let them order a couple and let them go ahead of me and let me see what I'll get. So I was a part of the early majority here, or maybe the late majority, because I let them order first. Most of us are like this. We don't want to be the first to jump in line to do something. We don't want to dress up as Harry Potter and wait overnight at the movie theater. We don't want to do that. All right. So when it comes to something like a new COVID-19 vaccine that we're offering to everyone, we want everyone to get it. Most people are going to fall into this early or late majority, or maybe have some laggards. And so here's a question that was posed to parents. Now we're years into this now. This was recently asked. Thinking about your children, do you think you would definitely, probably, or probably not, or get them the new vaccine once it's available for their age group? So I'm in the early adopter. I'm definitely going to get my kid vaccinated. But look at how this graph breaks down, and it almost mirrors that adoption curve right there. All right. Now, some of these people who are saying definitely not might cross over into probably or maybe will get it. But it's not unexpected for what we know about human nature in general. So there was a lot of frustration because there were low vaccination rates, and especially among children. I think it more or less fits with what we would expect. And at the very least, we don't react with anger when someone has hesitation to get the vaccine, because we know that there's this adoption cycle and it's going to take time for people to get there, and we can meet them there eventually. Now, this was also fascinating. This is looking at, going back to Republicans and Democrats, views on the percent who expect to get each vaccine, RSV, flu, and COVID-19, and then the percent who believe they're confident that they're safe. So, no big surprise here. If you are a Republican, you have less confidence in the vaccine and you have a low likelihood of getting the vaccine. But what's interesting is that, of course, the widest gulf here is between COVID-19, because that very polarizing issue, and a lot of people are dug in on that position. But look at RSV, where if you are a Republican, you have more confidence in the RSV vaccine, which literally is a new vaccine, compared to COVID-19, which has been given to billions and billions of people at this point with a very good safety record. So that gives you the absence of politicization, which shows that there's a lot of trust in this. And now, what's the one that's been around for years and years and years? That's the flu vaccine. And so the people who expect to get the vaccine, the majority of Republicans, just by a little bit, but the majority expect to get the flu vaccine. That's been out a long time. And so maybe this is a situation where the COVID-19 vaccine, after it loses a little bit of this polarization, is going to become much more integrated into the routine. And then this adoption life cycle is not really over the course of a few years, but several years. And it's more a normal thing that we do. And we see this gap sort of shorten a little bit. So this is just to show that I've learned to have more patience over time with people who are still vaccine hesitant, despite all the information that we've given them. As part of this is going to be psychology, and a lot of it is missing disinformation. But at the very least, I don't expect people to rush towards this. All right. Remain calm, patient, and good-humored. This is Ali Wong. If you've watched her Netflix specials, I think she's one of the best comedians in the world. I also think she's one of the best social commentators in the world, because if you listen to her comedy, of course you're laughing, but she's also talking about racism, she's talking about sexism, intersectionality. She is able to talk about things that silo us on a regular basis in a way that cuts across all of that. And humor is the vehicle through which she does that. So humor is remarkable. It has this ability to diffuse anger and anxiety. Not all the time, but a lot of the time. It can reinforce bonds. It builds a narrative, and you can clearly delineate what your position is. So if you're an X-Men fan, I'm not, so I didn't know who this person was, but it's Quill, and his superpower is spikes grow out of his face, and that's somehow gives him an advantage over other people. And so when I got this question, is the vaccine going to affect your DNA and, spike protein, all that sort of stuff? I kind of answered, I had this slide that you're not going to grow spikes out of your face, so no. And I usually would get a laugh, but that laugh was a tool to diffuse a little bit of the silos that people erect. And I would use that to introduce the concept that actually, no, it stays out of your DNA and doesn't do this and do that. But humor ended up being a way that I was able to introduce that concept. Now, here's one answer I got that brought a lot of these concepts together at the same time. So I was in a double AARP town hall, and I received a question about anaphylaxis from the vaccines. And at that point, I knew that the anaphylaxis rate was like 11.1 cases in 1 million people, and 75% of them happened within 15 minutes, and no one had died from it, and things like that. And I could have said all of those things. But after stumbling over trying to talk about the stats with people, I just broke it down to an analogy. And people have a general sense of risk when they go through their daily life. So raise your hand if you've seen a cow in your life. Is there anyone who's not seen a cow? All right. You've never seen a cow? Raise your hand. All right. Keep your hand raised if when you saw that cow, you feared for your life. All right, Pete, there's one person who fears cow. All right. There's actually someone at the CDC who tracks death by bovine. All right, it's about 20 to 25 people per year die because they get trampled or kicked by a cow. All right, so I answered this question. Well, it's rare. I could give you numbers, but let's just say you're more likely to get trampled by a cow than die from a reaction to the vaccine. And would you know, years later, people remember me for this comment. Like, you're the guy who said the cow thing. And it's so fine. But my point was that if you want to have a serious conversation about how dangerous these vaccines are from this standpoint, then we also had to have a serious conversation about how are we going to stay safe around cows, all right? So that introduces, it avoids using statistics. It's short, there's a visual because you can see the cow in your head. When I talk about this, and there's a little bit of humor there. That was my best moment. It just went downhill from there. Now, the other side of this is that oftentimes it did not come together that perfectly. And oftentimes when you did all these things, it's still, there's a lot of backlash. He who dares not offend cannot be honest. And one thing we have to talk about is that COVID, SciComm, and the backlash associated with it. More than 2/3 of scientists and public health experts reported negative experiences as a result of their appearances on social media. 22% death threats or physical harm, and ranging from attacks on credibility. Luckily, physical attacks were very low here. The people who were more susceptible or more likely to get these threats were people that were people of color and women, especially women of color. Lots of negative backlash there. And so I wasn't spared from this. And at one point, UVA had a security team who were tracking my calls to the hospital, because people were actually calling the hospital trying to speak with me and trying to page me and stuff like that, and would say like mean things. And this was the low point. Thank goodness there were people who decided to continue to push forward and charge hard. My family hit a limit where we said, you know what, there's a point where my family's safety is going to be the most important here. And so I avoided getting into a lot of these controversies. And when things got heated, like around election time and things like that, I intentionally toned it down because I did not want to deal with this. But I don't want to give the impression that it was all bad. I had a lot of fun doing this. I am happy that I'm more being a doctor on a day-to-day basis. I've done some cool things like Rochelle Walensky and Vivek, talking to them. They told me this meeting was supposed to be off record, so I'm not sure if I'm supposed to share this picture, but I don't think they'll do much to me at this point. This is my first time on NBC Nightly News. I was so excited. I was so nervous. And I talked to my mom afterwards and asked her, how did I do? And she was distracted because Miguel Almaguer is so attractive. So she didn't actually listen to what I said. This is a picture of my son getting his COVID-19 vaccine. And I texted that to Rochelle. She used to be my attending when I was at Mass General. Just thanking her for the work that she does. And then this was a cute moment at the middle here. This was a father in the UK whose son saw me on CBS, and his son saw a doctor that looked like him and started to wave to me. But, of course, I didn't wave to him back, and his son got upset. And so we FaceTimed him, and me and my son and his son had a chance to chat. So there were a lot of good moments that came out of this. I don't want to give the impression that, this was kind of a cesspool, because most of it was things that, validated me and helped me push on and helped me keep centered. Okay, last section, taking us back to the bedside. Now that I've talked about all this stuff, what do you do when you leave this auditorium? So I think I have 3 lessons. One, we do need to keep it simple. I said this earlier, but let's put this into context. So the average adult native English speaker knows about 20 to 35,000 words, and a working vocabulary is usually around 10,000 words by age 8. Medical students learn on average 15,000 new words over the course of 4 years. It's like being born again. There's literally a new language that we speak. And when patients hear us, my mom was in the hospital recently and heard me talk back and forth with her hospitalist, who was, we were just going back and forth. And she was like, son, I had no idea what you just said. Can you just translate that for me? It's literally a different language sometimes. So we have to be cognizant of that even the language that we're familiar with using amongst ourselves and that we think might be more simple, is still at a high level because we literally do learn a new language by getting to this room. Lesson 2, I think we need to use more narratives. So one thing that I did early on in the pandemic is I overemphasized the influence of data. I talked about data a lot, all the time. And, we established why that was problematic because people have a lot of trouble with data. And I wasn't using narratives. We tend to underemphasize the influence of narratives. This is Nas' first album, Illmatic. I was listening to it this morning while working on this slide. And his album is fantastic because he's rapping. He's a great lyricist, of course, but it's really the visuals that he gives you. He's telling a story of his childhood in Queensboro projects. And as he's rapping, you can literally see the situations and stories that he's bringing to life right there. And so even after I picked up this album again during the context of this talk, it had probably been 25 years or so since I listened to it. And I knew like 75% of the lyrics after having never thought about them for years because of that effect right there. So I believe the most effective clinicians are able to use both, that we can use the data when we need to, but we can use narratives. So before the pandemic, if someone was asking me about a complex situation, maybe in the ICU, should I intubate my father? Should I do this or do that? I might give them, a number or a likelihood and tell them, this isn't certain, but this is what we could expect, blah, blah, blah percent is blah, 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 blah. Now, I might still introduce some of that, but I'm much more likely to use a story from a patient I may have taken care of the prior week or the prior month. And I might say, I had a patient who was in a similar situation a month ago. This is what their father said. This is what they were struggling with. This is what they ended up doing. And sometimes, I've had family members that have been older too, and I've been in some of these situations, and I'll share freely what my decision-making process was. Again, giving them a story, a way to help people process what they're going through, but also a way to humanize between each other or between myself and them, because this is a way that we tell stories. And then remember, think about all the good experiences that you've had getting together with people. Most of the time, you were telling stories. If you think about it, we tend to remember that. And then lesson 3, I mentioned this before, but we need to understand the power dynamics that our patients face. To be human is to fundamentally want to influence the world. And I'm not talking on like a Steve Jobs or a Mother Teresa sort of level. I'm talking about granular to the level of a chair that's overlooking the seawall. And let's call this the Mediterranean. Now, I bet you most people, if you were to sit here and watch this, a person who walked up to that chair and sat down in it would probably make a little micro adjustment to the chair before they sit down in it. I think that chair is perfectly positioned for a good view, but most of us will do something to it to make it more personal, to make it our own. That's a way of influencing the world. Now, if you've consumed healthcare, most of us have at this point, it's a very disempowering experience. Even myself, as a physician who spends a lot of time in the hospital, I know all the things, I know the people. I broke my elbow skateboarding. Don't ask any more questions. It's a long story. Happened during COVID. My son's fault. He was okay, but I felt very disempowered. I felt like I was not in control. I was in pain, and people were very nice to me. No one was upset. I didn't feel disenfranchised or anything like that, but I was still very disempowered, despite the fact that I knew the views for the ultrasound for the nerve block before the surgery. I knew the resident who was doing, the procedure. I still felt disempowered despite being very comfortable in that environment. Now, we run the risk of exacerbating this gap if we don't understand that notion of powerlessness that our patients have. And so when we hear about difficult patients or difficult families, I believe that what's often happening is the patient's really trying to tell you, no one's listening to my concerns. I have no influence over my team. The team doesn't value me. There's a sense of powerlessness that we can sometimes feed into if we don't acknowledge it. Difficult team interactions. Let's, even taking this out of the realm of patient care, but just how we interact with each other in the course of taking care of patients. Inter-team conflict oftentimes boils down to no one's listening to my concerns. I have no influence over the team and my expertise is not being valued. The team doesn't value me. All right. This gets to the concept of emotional intelligence. There was a nice Harvard Business Review article on it. This is basically your ability to accurately perceive your own emotions, understand your signals and other signals, and then ultimately manage them. And one of the reasons I love the ICU, I love the team-based environment, is I get to do this on a daily basis when I'm on service. And so, of course, I'm thinking about the pathophysiology. I'm thinking about the teaching points I'm going to give on sepsis or mechanical ventilation. But I'm also thinking about the dynamics at play right here. There's a nurse practitioner who's talking to me. There's a respiratory therapist over to the left right there. There's a nurse who's at the back right there, and other team members. And I'm thinking, am I getting the right emotional signals from everyone? And sometimes, there's reluctance to raise your hand and say, I think what you're doing doesn't make sense. Because there's this hierarchical relationship. And I try to dissolve that. But one of the ways I do that is try to open up the conversation and make sure that people know that if you're here, I see you and I'm going to ask you what your opinion is. And my team knows that about me now, that they don't speak up. I'm going to ask them. And so they're just more likely to chime in and say, actually, I think this vent strategy doesn't make sense because I tried this 2 days ago and this is what happened. And so there's like a parallel thought process that's going in my head about what do I need to do for the patient? What do I need to do for my team? And even in the most acute situations, I do this in codes. I'm at the head of the bed. Luckily, I don't have to run the code. My fellow runs the code, so I can just kind of be a fly on the wall. But I'm observing the team dynamics in a very stressful situation where people need to execute at their highest level. That means there needs to be a lot of emotional intelligence in the room. And you need to be able to read signals that people are giving you either intentionally or non-intentionally. All right, so this boils down to what I envision as a wellness stool that you can apply it to your professional life, to rounds, you can apply it to your personal life. But there are 3 parts of it. One is your sense of value. Does your institution value you? Does your partner value you? Does your community group value you? Your sense of agency. If something here doesn't make sense, can I change it? Maybe if I can't completely revolutionize it, maybe I can just make something a little bit better. And then 3 is your sense of community. Do you have people who are around you who are like-minded, who can help you out when you're feeling down? Now, oftentimes, I'm putting on my faculty development role hat here. Oftentimes, when there are problems with the faculty, something about this stool is off, and usually it's 1 or 2, and that's a big problem. And if it's all 3, then that's a crisis, and that's something that we have to do something about. But it applies in the hospital as well too, and it applies for our patients. Now, the last thing I'll say is that, this is actually hard. Like I can put a slide up and say, be more emotionally intelligent. But it's actually hard. It's hard to do because we're reactive sometimes. I told you I was going to come back to my daughter. All right, here it is. Ruby is, she's like me, and that's an issue. She is a doer. She is one who likes to jump in. She wants to have the experience. This is her with our neighbor who's a baker, and she's learned how to bake at 5 years old. Anyway, she pooped in a trash can one night. All right, let's just get right to it. She pooped in a trash can. That was at her bed. I'm an ID doctor. I didn't like that. I think anyone would not like that, but me in particular, because I'm thinking about C. diff and all, So she goes to, I put her to bed, and I go to give her a kiss, and I smell excrement. And I asked her, like, did you fart? Like, what happened? And she said no, but she gave me that look. Anyone who's a parent knows that sometimes you get a look from your kid that there's a lot behind that answer that they gave you. So I knew that, but I couldn't figure it out. Walked away, came back, and same thing. Nothing happened. I looked down and I see poop in a trash can. And I should have led with emotional empathy and understanding and channeling all those books that I read when I was when she was about to be born. But I channeled the energy of my ancestors and came from within, and I led with my diaphragm and my chest wall muscles and a lot of anger. And the whole house, the nature of the household changed that evening. She went to bed. I never found out the answer because she was so upset. But in the morning, I asked her, Ruby, why did you poop in a trash can? And she told me that she had a book that my wife and I gave her about how the human body works. And there was a section on your poop and how the composition of your poop, how it looks, might indicate your health status. And she was not happy with the fact that if you pooped in the toilet, it went into the water, you had to flush it, and you could not really evaluate it. So she said, well, if I poop in a trash can, I'll be able to look at it and tell how healthy I am. But the problem is, what do you do after that? And so she decided to try to make it go away, and she thought that that would work, and it didn't work. So if I'd have just slowed down and asked the question, why did you do this? And like not let my anger and my ancestors lead with that, then I would have found out that she's going to become a GI fellow at some point. All right. So last slide here. In summary, in my opinion, I think people in the room here should embrace communication with large audiences. And I'm not talking necessarily social media or, high-level things, but, presenting at a conference or around or something like that. There are many ways to engage. Choose the method that works for you. And then communicating with large audiences can help you communicate with your patients and with your teams better. And that's my talk. Happy to take any questions.
Bill, that was fantastic. Thank you. We have time for a couple of questions, so I'm gonna, throw it out to our live audience, unless the Chiefs already have a few on board. Dr. Stenyam.
Thanks, Dyson. That was really excellent. Brought back a lot of COVID memories for me. I'm sure you watched a lot of COVID communicators nationally talk about COVID through all different stages of it. What was the thing that we did poorly? Like, if you could put a finger on and watching everybody have this discussion with large audiences, what are the things that you think, we did poorly and could have done better in hindsight?
Yeah, that's a really good question. So the question was, what did we fail at in communicating early on? And I think, the answer for me personally was, I did not do as good of a job recognizing the power dynamics at play when I was giving public health communication. When I came on you heard my intro, like there's a lot going on there. And there's a lot of power dynamic that can happen if someone like me is talking to someone who's in a community that's trying to figure out what to do. And what I tended to do early on was just say what the public health advice was and why. But I did not introduce the uncertainty around it and the back and forth that sometimes went into those recommendations. And sometimes not even also, how I interpreted that. So, one was, when the CDC said, oh, you can come back, you can, 5 days, like you're good. No tests, maybe tests, I don't know. I had a lot of disagreement with that. And I think early on, I might have just said, this is what they said and this is why. But later on, I said, you know, I disagree with this. I think it might be reasonable, but this is why, and this is what I'm going to do. And what that does is it takes away some of the mystique behind the decision-making process in science. And sometimes we talked about this, that you know, Peter Offit would often disagree and things like that. But science by nature is a collaborative back and forth. And we did not do as good of a job introducing that concept. And that led people to still feel disempowered after we got that information. And so I wish that I had done a little bit more of explaining to people what's the wiggle room and what's the gray area behind that black and white recommendation.
We're right at 1 o'clock. So I think we'll have to call it here. But Dr. Bell, thank you very much. If there are other questions, maybe you can stick around for a few minutes.
Sure. Thank you.
Thank you.